All right, everyone, welcome to the Nursing Lab. Today, we are diving deep into the world of intrapartum care. This is where the magic happens, but it is also where you need to be sharp and ready to move. We are talking labor, fetal monitoring, and those high-stakes complications you need to know for your exams. Let's get this party started with the biggest question every new nurse gets. Is this the real deal or a false alarm? Check out this chart on the board. The absolute golden rule for your exams is that true labor equals cervical change. If that cervix isn't dilating or thinning out, it is false labor, often called Braxton Hicks. In true labor, those contractions get closer together, they last longer, and they hurt more as time goes on. Usually that pain starts in the lower back and wraps around to the front like a tight belt. In false labor, a warm shower or a little walk might actually make the pain go away. Not the case with the real thing. See this drawing? On the left, we've got a cervix that's closed up tight. On the right, that cervix is thinning out and opening up. That is effacement and dilation in action, which is our next big topic. Let's keep this momentum rolling into how we actually measure that progress. Next up, we have the bread and butter of labor progress: dilation and effacement. Look at the visual. Effacement is all about how thin that cervix gets. We measure it in percentages. You start at 0%, which is thick and long, and you go all the way to 100%, which means it's paper thin. Dilation is the opening. We go from 0 to 10 centimeters. Remember this: you cannot have the mom start pushing until she is fully dilated at 10 centimeters. Pushing too early causes swelling and can stall the whole process. Now, let's talk about station. This is where the baby's head is sitting in relation to the mother's pelvis. Think of this like a countdown. 0 station means the baby is engaged right at the level of the ischial spines. If the baby is high up, we use negative numbers like -3. As the baby moves down toward the exit, we move into the positives. +3 means that baby is almost here. We also use something called the Bishop score. It tells us if the cervix is ripe or ready for labor. A high score is great. It means the cervix is soft and ready to go. A low score might mean we need to use medications to help ripen that cervix first. Got that? Because we are moving straight into the stages of labor. All right, let's break down the timeline. Labor isn't just one long event. It happens in 4 distinct stages that you absolutely have to know for the NCLEX. Look at the timeline I'm putting up. Stage 1 is the long haul. It's all about getting that cervix from 0 to 10 centimeters. We split stage 1 into 2 parts. You've got the latent phase, which is 0 to 5 centimeters. Then things get real in the active phase, also called the transition phase on some exams, which is 6 to 10 centimeters. In this active phase, we expect that cervix to change about 1 centimeter every hour. Stage 2 is the workout. This is the pushing phase that ends with the birth of the baby. Then, don't forget stage 3. The placenta has to come out. Watch for the signs of the placenta separating. You'll see a sudden gush of blood, and the umbilical cord will actually look like it's getting longer. That's how you know it's coming. Finally, stage 4 is just the first couple of hours of recovery where we watch mom like a hawk. Boom! Now that we know the stages, we have to talk about how we keep an eye on that baby during the whole process. Now we are getting into the tech. Fetal monitoring is how we see how the baby is handling the stress of labor. We can do this 2 ways: external or internal. Most of the time, we use external monitors. One belt has the transducer to listen to the heart rate, and the other has the toco to feel the contractions from the outside. But listen closely. The external toco only tells us how often and how long the contractions are. It does not tell us how strong they actually are. To know the real strength, we need the IUPC. That's an internal pressure catheter. Internal monitoring is way more accurate. We use a fetal scalp electrode, or FSE, which attaches right to the baby's head to get a perfect heart rate reading. Just remember, You can only do internal monitoring if the mother's water has already broken. Now that we have the equipment set up, let's look at what those heart rate patterns are actually telling us. When you look at that monitor strip, the first thing you need is the baseline. This is the average heart rate over a 10-minute period. Normal baseline is between a 110 and 160 beats per minute. If it's over 160, we call that tachycardia. Watch out for infections. If it's under 110, that's bradycardia. The next big thing is variability. This is the squiggle in the line. We want to see those little fluctuations because it tells us the baby's nervous system is working. Moderate variability is the goal. That means the baby is happy and healthy. If the line goes flat, that's absent variability, and it is a major red flag. It means the baby might not be getting enough oxygen. Finally, look for accelerations. These are little spikes above the baseline. If you see those, celebrate. It means the baby is doing great. But what happens when the heart rate goes down? That is where things get tricky. Let's look at VEAL CHOP. All right, everyone, this is the most important memory trick for your exams. You have to memorize VEAL CHOP. It tells us what kind of deceleration we're seeing and what is causing it. Check the board. Variable decelerations come from cord compression. Early decelerations are just head compression, usually when the baby is moving down, and those are actually okay. Look at the shapes. Variables look like a V. Earlies mirror the contraction. When the contraction goes up, the heart rate goes down. But lates? Those are the scary ones. They start after the peak of the contraction and mean the placenta isn't doing its job. When you see those lates or bad variables, you go into lion mode. Turn the mom on her left side, give an IV fluid bolus, get that oxygen on her, and stop the Pitocin immediately. This is called intrauterine resuscitation, and it is your top priority as a nurse. We've got the heart rate down, so let's move into what happens when things get physically stuck during birth. Now we're getting into the high-stress stuff. Shoulder dystocia is a major emergency. It happens when the head comes out, but that shoulder gets stuck right behind the mother's pubic bone. You'll see what we call the turtle sign, where the head pulls back against the perineum. This usually happens with big babies, that's macrosomia, or if we're using vacuums or forceps. As the nurse, you have two big moves. First is the McRoberts maneuver. You pull the mom's knees way back toward her shoulders to open up that pelvis. Second is suprapubic pressure. You take your fist and push down just above that pubic bone to try and pop that shoulder loose. Never ever push on the fundus, the top of the uterus, because that just wedges the baby in tighter. Once the baby is out, you've got to check them for injuries like a broken collarbone or brachial plexus damage. This is a fast-moving situation. But that's not the only emergency we need to be ready for. Let's talk about the umbilical cord. Next up is the prolapsed cord. This is a terrifying, life-threatening emergency. It's when the umbilical cord slips out of the cervix before the baby does. When that happens, the baby's head or body starts squashing the cord, which cuts off their entire oxygen supply. This usually happens right after the water breaks if the baby isn't fully engaged in the pelvis yet. If you see this or feel it during an exam, you have to act fast. You put on a sterile glove, reach in, and you actually push the baby's head up and off that cord. And here is the crazy part. You do not take your hand out. You stay there, holding the baby's head up to keep that blood flowing all the way into the operating room until they cut for a stat C-section. Gravity is your friend here too. Get the mom into a knee-chest position or Trendelenburg to help slide the baby back toward the fundus. Now, sometimes the water breaks and it's not clear. It's stained. Let's look at what meconium means for our delivery. All right, class, let's talk about when the amniotic fluid isn't clear. If it looks green or brown, that's meconium. Basically, the baby had a bowel movement inside the womb. This can happen because the baby is post-term and their gut is just mature, or it could be a sign of stress like hypoxia. As the nurse, you've got to document the color and call in the neonatal resuscitation team to be ready at birth. Now, if we have low fluid or the baby is squashing that cord causing those variable decelerations, we might do an amnio infusion. We use an IUPC to pump warm, normal saline or lactated ringers right back into the uterus. Think of it like adding more water to a pool so the baby can float better and stop pinching that cord. Just remember, you must have an IUPC to do this, and the water has to be broken already. To wrap things up, we have to look at the final way a baby might enter the world: the C-section. Finally, we have the C-section. Sometimes a vaginal birth just isn't safe for the mom or the baby, and we have to go to the operating room. Check the board for when we do this. If the baby is in a weird position like breech or transverse, or if they're just too big, that's LGA, or large for gestational age, we're going to surgery. We also do it for active infections like herpes because we don't want the baby catching that on the way out. And of course, if that heart rate is looking scary or the cord prolapses, it's a straight shot to the OR. And that is your crash course on intrapartum care. Remember, true labor is all about cervical change. VEAL CHOP is your best friend for fetal monitoring, and Lion is your go-to for those scary decelerations. Keep these memory tricks in your head, and you'll crush your nursing exams. Thanks for watching this whiteboard session, and I'll see you in the next video. If you want me to dive deeper into any of these specific topics, or if you've got a question about something I covered, drop a comment below. I'll be glad to help you out and get those aha moments clicking.